Gardner syndrome is a syndrome of incidental findings. How important these incidental findings are is that in every instance we find incidental findings such as sebaceous cyst, epidermoid inclusion cyst, or fibromas, the occurrence of osteomas with a marked propensity for the facial skeleton often will precede the occurrence of multiple intestinal polyposis. Now, in Gardner syndrome, we will find, unfortunately, a transformation, a malignant degeneration of these intestinal polyposis, which occur most frequently in the colon and in the rectum. If we would just find in our patients who have a past history of a rectal polyp, the occurrence of a odontoma or an osteoma in the jaws, and advise this patient and his relatives to seek additional medical examination, that is, from a gastroenterologist or a proctologist, how many lives can we save? Now, if we can see our first slide today, we'll show a family of 4 generations, first described by Dr. Gardner. Now, in this family, we find that the grandmother transmitted to 2 of her 3 siblings cancer of the colon that was transmitted to 2 sons. These children also transmitted to their offspring the occurrence of intestinal polyps and cysts, sebaceous cyst or dermoid cyst of the skin. Back in 1936, Dr. Kurt Thoma described the occurrence of multiple osteomas and sebaceous cyst. A few years later, additional report was described in which there was the occurrence of sebaceous cyst and intestinal polyposis on a familial basis, but it was to Gardner and his associates that described the occurrence in 4 generations of intestinal polyposis that underwent malignant transformation in these patients. Now, just by history or by examination, that we find that a number of these patients have not developed as yet adenocarcinoma in the pre-existing polyps. However, that does not mean that these patients will not subsequently develop this intestinal polyposis at some future date. Once one of these families is discovered, it will be necessary to examine their lower GI at least every year for the rest of their lives. The occurrence of multiple fibromas, sebaceous cyst over the trunk of one of these individuals should alert us, especially when we find that these patients might have what we would think are multiple exostoses or inostoses of the jaws, or even the occurrence of composite odontomas, that if we find that any of these patients have these sebaceous cysts or epidermoid inclusion cysts with the aforementioned lesions in the jaws, then these patients should be referred to the gastroenterologist. Now, this lesion here appearing rather diffuse, and there's resulting in some displacement of the contiguous teeth. It's suggestive of a radio-opaque lesion that we might consider to be an osteoma. And we see that clinically this lesion, it's a multiple bosselated surface, and find that there is a cortical periphery with a medullary portion of the bone demonstrated both histologically and radiographically. And this was a classical osteoma occurring on the lingual aspect of the mandible. This might be thought to be just an innocuous mandibular torus. However, with careful examination of the patient, insofar as the sebaceous cyst, the occurrence of fibromas that may also occur, and it's not infrequent to see that the occurrence of desmoid tumors or fibromas occurring in lines of incision in the skin. It's not infrequent to find that after these patients have been operated on for their intestinal polyposis, that they will develop these desmoid tumors in the line of the incision over the abdomen. It is not at all uncommon to see some of these patients have marked facial deformity, especially if some of the lesions occur over the face with a great deal of frequency. We see here at the angle of the mandible, there is a lesion that is certainly is bony hard, firmly attached to the mandible, and the patient was aware that this growth was slowly increasing in size for the past 5 or 6 years. He was a 14-year-old young man that was able to find on the GI series multiple intestinal polyposis. Now, as opposed to the Peutz-Jeghers syndrome, we can find these multiple intestinal polyposis throughout the GI tract, from the duodenum to the rectum. However, in Gardner syndrome, we find that most of the intestinal polyposis occur in the colon, also in the rectum, and there have only been 2 cases to date that these polyps have been found in Gardner syndrome in the small intestine. So it is the colon and the rectum that we should direct our attention in Gardner syndrome, because it is here that these patients will develop adenocarcinomatous malignant degeneration in these intestinal polyps. The preceding case shows that this lesion has a broad attachment to the inferior border of the cortex. It's been our experience that there is a marked affinity for the inferior border of the mandible for the occurrence of these multiple bosselated osteomata. However, other bones in the craniofacial complex show the occurrence of these osteomas. We find a patient with a lesion here in the calvarium. Over the parietal bone is one of these osteoma. Now, the osteomas, these bone tumors, do not undergo malignant transformation, as do the lesions in the intestine. In every instance, we will find in Gardner syndrome these interesting findings of osteoma, along the inferior border of the mandible, the sebaceous cysts, the fibromas in the mesentery. We find that these lesions will precede the occurrence of the polyps in the colon. This patient has several lesions, osteomas that are occurring in the calvarium. Again, at the inferior border of the mandible, this osteoma has a radiolucent periphery surrounding the central core of radioopacity, somewhat like what we might see in a osteoid osteoma. Now, any time that we see these exostoses of the maxilla or the mandible, or what we think are mandibular tori, these patients should be questioned whether or not that there has been any past history of intestinal polyposis, that they've had any melena, they have had any GI complaints, or if any of these patients have any member of their family who has ever had a prior history of polyps of the colon, or have had any malignant occurrence of lesions in the colon or in the rectum. These are histologically indistinguishable from the osteomata that occur in bones anywhere else in the body, and they are histologically indistinguishable from the mandibular tori or the exostoses that occur with a great deal of frequency in the jaws. We should be very much aware that we can find also composite odontomas in this syndrome. The occurrence is mentioned of fibromas and of desmoid tumors. Here is one that is quite large, that is involving the floor of the mouth. The anterior portion of the tongue is being displaced superiorly. The occurrence of epidermoid inclusion cyst any place on the body, and the occurrence of desmoid tumors should direct the clinician to a thorough study of the lower GI tract in every instance. Because, as we see, the occurrence of multiple polyposis here in the colon of this individual, and we find that there has been malignant transformation take place in the colon of this individual. Find that on the barium study that the myriad of little radiolucencies that are showing up here in the colon, find that there is a marked susceptibility for these to undergo malignant transformation with metastasis to the regional lymph nodes in the individual. Now, recently, Dr. John Pleasance at the University of Texas Dental Branch had the occasion to examine a young man, 11 years of age, that has, again, this bossulated osteomata occurring at the left angle and inferior border of the ramus of the mandible. There are multiple radiolucencies that are occurring throughout the mandible, and a suggestion associated with these bilaterally impacted cuspid teeth that there might be a little supernumerary tooth. This might be suggestive of the odontomas that we had discussed earlier, and that a number of other authors have reported the occurrence of composite odontomas with this syndrome. Now, when we find and examine the young man's 33-year-old father, they are also, when we look at the mandible, there are multiple osteomas at the lower border of his mandible. This individual also had some what looked like to be supernumerary teeth associated with a little cystic lesion in the anterior maxilla. This individual was referred for examination to the MD Anderson Hospital. It was found that following a colectomy procedure, he had adenocarcinoma of his colon. 3 of the siblings of this father were unaffected insofar as their jaws are concerned for multiple osteomas. However, this does not infer that these siblings may not also subsequently develop the intestinal polyposis with malignant transformation. The frequency of the occurrence of mandibular tori and the occurrence of compound odontomas in the jaws certainly should make us ever alert to the presence and the occurrence of this syndrome. Now, the infrequency with which this syndrome is reported does not in any way reflect its true incidence. Unfortunately, too many incomplete examinations, especially in the area of dental röntgenography, the attempts to be brief in case reports, even purposeful deletions in scientific articles, all of which might indicate that there were just incidental findings that we have mentioned, such as these epidermoid cysts, the fibromas, the osteomas, these odontomas that we mentioned. These are all factors and findings that we must be aware of. If we don't record these and don't look for these, then there's going to be failure in the diagnosis of this syndrome. There is certainly a tremendous clinical importance to the findings of these intestinal polyposes which undergo malignant transformation. Just because, as we mentioned, that there may be a negative report initially, because the other components of this syndrome have already made their appearance, we may find that these polyps will show up several years later. It certainly is going to be very important that we notify the patient as to the legacy which he may endow his descendants.